My name is Dr. Mary Claire Haver. I am in the U.S., I am a certified obstetrician gynecologist. So we do our, 4 years of medical school after uni. So we do uni and then medical school, and then we do, you get to pick a specialty, and I picked OBGYN. And then that was another 4 years of training. And then in 2018, became a certified nutritionist. It's called Culinary medicine. And it's an elective thing because I became so interested in nutrition and realized that in menopause, something very special is happening to women, and our usual methods of maintaining our body composition and weight and health, things kind of change dramatically. And so I sadly had to wait till it happened to me before I got interested to seriously approach the topic. But much like you, we do not have universal health care, which is, in the U.S., we are a fee-based system, which leaves millions and millions and millions, a huge percentage of our population without any access to health care. Which is why our healthcare outcomes are so poor compared to other industrialized nations. Menopause care, like in the UK, has been undervalued, understudied, under-offered, and it's also given rise to, because women are so desperate to get help, to get care, to get anything, a kind of rise of people going outside of certified studies and offering things that I think are meant to be helpful initially, but are being abused and very, very expensive. So it's only about 30% of women are offered any form of hormone therapy. And if they go in, 70% of women, they've done studies in the US, go in discussing symptoms, and only about 30% of them where it's acknowledged or offered any treatment when they reviewed the.
So we have very similar statistics. In fact, if you look at some of the studies, women will go in with perimenopausal or menopausal symptoms, and 70% of the time they'll leave with antidepressants. And that isn't something, usually on the whole, women don't want that. They want to be discussing lifestyle, nutrition. They want to be discussing hormone replacement therapy. So I wanted to crack on and ask you your first question, if that's okay.
Sure.
Obviously, I know that you talk about HRT a lot. What are the views around HRT in America? How readily is it offered?
So it's not readily offered. From the studies that have been done, less than 30% of patients who go in discussing perimenopause, menopause symptoms are offered. And a lot of that has to do around lack of training, lack of education, the way we're training our women's healthcare providers, and a lot of the misconceptions that are still pervasive. I mean, I can't tell you how many thousands of comments a day that I get from followers who are like, but it causes cancer, but it causes cancer. And I have to break down the nuances of, here's the actual risk, 1 out of 1,000 women, otherwise your overall, and what they don't realize, it's more than hot flashes and night sweats, which are very, very important to, manage and control because they're so life disruptive for so many of us. But it's also the long-term health benefits. The all-cause mortality rate decreases, the colon cancer decreases, the risk of, of course, osteoporosis, we've known that for years, but more and more information, if you look at the cardiovascular, articles that are coming out showing if you start young, decreased risk of heart disease, the neurology articles that are coming out, decreasing risk of Alzheimer's and dementia if you start young enough, and so really trying to get people on board to at least consider it and open the conversation with their doctor. Where I fight is the misinformation. And so I'm just trying to empower women to have more informed conversations with their doctors and put their foot down.
And this is where we bonded so well, because I'm exactly the same. Because
this is where I've seen some of your information and I'm like, wow, there yet. So both the American College of OB/GYN and the North American Menopause Society have come out to say that they kind of lump all the estrogens together. And so we don't, I'm curious to know, are there studies? Of course, the WHI studies were done with Premarin and the synthetic form of progesterone. And so, but what clearly ACOG and NAMS is saying, our governing bodies, at least the ones that I follow, is that, well, I do offer those, the non synthetic forms is what I do, but I tell them we don't have studies that are showing that these are safer or better. But there's a lot of misinformation here in the US around these bioidentical compounded, very, very
Yeah.
expensive pellets and, things, and physicians are making a lot of personal profit off of this and not offering any other option. Like, this is the best, it's safe, it's all these things. And I give them more when I'm personally counseling a patient. I'm saying, we have lots of options. Here's the ones that were in the study that did show an increased risk. We're not real sure if these are going to have the same risk, but it is a different formulation. And, here, what can you afford?
Yeah.
And they're like, oh, what's the best? I'm like, well, I don't, we were just treating symptoms here and we don't have a clear winner yet. So
the way that we do it with HRT is that the bioidentical compound hormones, the MRHA, because we have a medical health regulatory body, they have categorically said that they're not safe and we don't prescribe them at all. But we do
okay.
have body identical HRT. So
And
hang on, I'll show you. I carry HRT around with me because I show my patients. I carry vaginal estrogen, marina coil, you ask her. But so we have preparations like this. So this is body identical transdermal, goes onto the skin, and this is made out of root vegetables and yams. And we are having a national shortage of this in the UK because of supply, but that's a whole other conversation. But if we talk about risks with this, so in the UK, what we look at is that the studies aren't far, but we know that because it goes through the skin into the fat cells, into the bloodstream, because it doesn't go through the liver, so the liver on the right side, so it doesn't go through the liver, then it doesn't trigger off the clotting factor. So your risk of clot is not there with transdermal. Do
right.
we agree on that, Dr. Mary
Agree.
Claire?
Yeah. I
Perfect.
often discuss the transdermal, and it's usually cost prohibitive. If someone goes with oral, it's a cost issue.
It's a cost issue. So this costs roughly about £9 in the UK, when the tablet version is about £1.20. Can you believe that? So
Right.
obviously the NHS want to prescribe the tablet version. So
The
cost is
the patches, if you paid out of pocket without insurance supporting it, would be $300 to $400 a month for transdermal. And I'd have to
ridiculous.
found, which is kind of hit or miss, and they're not regulated, to find what you are offering there. I'd have to find a private compounding pharmacy.
So we are campaigning really hard, and I'm part of this parliamentary group. So we're actually taking it to the government now, and we're trying to make sure that we get HRT to the best, because women are really being limited, and because of the risk, they worry about that. So I want to be just that we've got two doctors on the line together from across the pond, and we both agree transdermal, body identical estrogens do not increase your risk of clots. So if you've had a stroke, if you've had migraines, if you have had a DVT, if you've had a heart attack, then actually having transdermal body identical estrogens are safe. And you can also get body identical progesterones, and we have something called Utrogestan in England that we give to women. And therefore, we shouldn't be putting women off in regarding to having HRT if they have migraines, heart attacks. And you said something really significant there, Dr. Mary Claire. You said that women who are younger who take HRT, actually they do far better in the long run in regards to heart disease.
Yes, yes. And we're seeing multiple disease states. New data is coming out, at least out of the, when I do PubMed searches, that are showing women on, finally doing studies on women, finally looking to see whether or not they were on HRT. And so all of these, and it's usually female researchers who are in their 40s.
They're the ones interested.
And so we're seeing, multiple disease state improvements or not deterioration if the women happen to be offered and chose HRT. So it's very exciting for me, to see this overall improvement in women's health.
So the other risk that we always get is that the lining of the womb, the other risk that we get is the lining of the womb will thicken up. So endometrial cancer is a real worry. But in the UK, for a woman that has a womb, and I'm sure that this is exactly the same because I know that you've done videos on this, for a woman that has a womb, she has to have estrogen and progesterone together. She would never be given estrogen alone.
Exactly.
And we try and make...
Yes, we are the same. I just the Prometrium, which is bioidentical, and it's very inexpensive. There's a generic version, and most people can afford it. We don't have a good. I'd have to do another compounding pharmacy, and again, I can't offer that to everyone. That's just not available.
This is where one of the common questions, so because I put it out on my social media this morning and I kept getting asked, and this is where I really wanted your expertise. So a woman has written to me to say that I'm 45 years old. I've had breast cancer in the past, which was very small, localized, taken out. But my doctors have told me I cannot have HRT. What would you advise? So
So
alternatives to HRT.
Yes. So when they are not, when they have red flag, what I call, my clinic, a red flag or an absolute contraindication to HRT. Not every woman is a candidate, of course, where science shows that the risk may be more than the potential benefits. Then we look at individual symptoms as much as we can. And so if it's hot flashes and night sweats, then we start looking at things in the US like clonidine. We recommend clonidine, Neurontin. A lot of my breast cancer patients who were in chemically induced menopause due to tamoxifen, Neurontin can be very, very helpful. Actually, some of the SSRIs are helpful with hot flashes and night sweats. But again, I think they're overused. They just get thrown at women here in the US because I'm sad to say, I don't know if it's happening across the pond, but it's all in her head is a common diagnosis here when a doctor's frustrated can't figure out what's going on, that they just weren't taught and trained the nuances of perimenopause. They can recognize menopause because it's a simple blood test, but perimenopause, we weren't taught in training. We knew it was a thing, but there were no education around how to recognize it, how to treat it, treatment options. No treatment options were ever taught to me until they were fully menopausal. And I think that is where I'm trying to make strides, to make people realize that there are options for you. So, hot flashes, clonidine, Neurontin is kind of where I start. Possible SSRI, but there are a lot of side effects with that, decreased libido, that's a whole nother issue. If it is, bone density, then we're looking at some of the medications to strengthen the bones. There's multiple options here. The other issues, I have to go to the cardiovascular literature, or, she's having palpitations. I'll consult a cardiologist and look, we know that there are estrogen receptors on the SA node. And it just depends on the sinoatrial node, that are increasing her palpitations. And so, I'm trying to promote that, I'm doing a lot of cross specialist work, trying to get these physicians to recognize that perimenopause is going to make a new onset or worsen these symptoms, and she can't take hormones. So, you've got to help this woman out.
So in the UK, what we do is that we have very similar things, and it's the role of the general physician to, so if a woman comes in to see me and she's 45 years old and she's having all the symptoms that I think are perimenopausal and she's still having periods, is that if she's getting palpitations or if she's getting migraine, we will investigate those just to rule out that there's no other underlying reasons. For example, she doesn't have palpitations because there's a heart-related condition. And then they all come back to the GP, and it's solely on the responsibility of the GP to initiate HRT. But then GPs aren't readily trained. I had to go away and do a special training and courses, etc., as you said that you've had to do. So the difficulty is that the woman is left in limbo. The biggest issue that we have is ethnic minority communities are the worst adversely affected because they don't know exactly how to ask the GP. Black and Asian women are more likely to be dismissed because of their symptoms, particularly because they don't complain of hot flushes. So I found that with a lot of Asian women, that they would never complain of flushes because their context of a flush is that, well, if I go to a hot country like Dubai, then that's a flush. Getting a flush in the UK is not really a flush because our weather is so much colder here. Mm-hmm. And so therefore the readily available of giving them management of this transition in life that they're going through means that they're worstly adversely affected later on in life. And you said something really interesting at the start of our conversation. You said that it's the long-term benefits, and I think women aren't told enough about that, are they?
And we're just discovering them. So I mean, even like American Council of OBGYN and NAMS haven't, they're hinting at it, but they're not it takes committee work and you have to come together and change the guidelines. And I mean, it takes years for these things to be recognized. But in the meantime, I'm just treating.
Yeah. And are you treating women sort of in the UK now? HRT is a treatment for osteoporosis. So I start women who are perimenopausal, who we've discovered by a DEXA scan that they've got osteoporosis. I start them on HRT because I say to them, you will not thank me now, but you'll thank me in about 10 years later when you don't have a hip, a fractured neck or femur.
So it depends on, I have, depends on where she is in her journey. I will either do a low dose birth control pill, if she still has a uterus, or I'll do just plain estradiol. If she has had a hysterectomy, or, if she has a Mirena coil, then I will just do continuous estrogen to help her,
Yeah,
through the transition, or a progestin
that's what we
containing.
do.
Yeah.
Yeah, that's
And
exactly what we do.
uh, if she's very close, then I will probably start HRT level doses. So really the only difference to educate your followers is the dosage. And so, they are more, it's more synthetic, but that's what they're cheap. Again, cost is an issue here, and getting insurance to cover it. I mean, I have so many political things I have to deal with when I'm trying to treat a patient, and misconceptions, and, um, people out there who I'd like to know what there's people are doing these Dutch tests, or is anyone doing that in the UK, the urine
No,
dry that
yeah,
um,
I only heard that from you. I never heard about these Dutch
there's one
tests before.
world that does Dutch testing, and so many of these physicians who are doing now I do work, my office right now is in an aesthetic center because it was in a beautiful location and I could rent it for a very reasonable price. But I'm not an aesthetic physician. But so many of these doctors who are trying to increase their revenue get into, Botox and facials and vaginal tightening and all these things, and then do this Dutch testing where they make you collect your urine for several days. And to my knowledge, urinary metabolites have not been shown to be correlative to blood levels, because estrogen is secreted in both the urine and the, feces. So, I mean, estrogen metabolites. So there's a lot of misconception around that, because a lot of these doctors sign up for these courses. They take, a 1 month course to learn how to do Dutch testing, and then they go right to the pellets. And so pellet therapy is it's outlawed in the UK, thank God, but no one's listening. Women don't count here in the US to realize that these formulations are not tested, they're not controlled. And when the Food and Drug Administration did secret shopping and went and sampled the 12 biggest compounding pharmacies in the US, it was a 34% discordance in what the company said was in it and what
Goodness.
was actually in it. It's not safe. And so
I'm
and
so
it's
pleased that you're highlighting this, because I think that when it comes to the menopause, it sometimes is like the new black. Women are vulnerable at this stage and they are looking for treatments. And unfortunately, what happens is like selling snake oil to women, and then they will go along and this is something that we're really conscious of in the UK. That's why we've got a parliamentary group set up to try and make sure that we don't allow women to spend needlessly, and everything should be under the umbrella of the NHS. Yes, the NHS isn't perfect, and I completely agree with that, but we are trying to make sure that at least then women aren't then spending thousands and thousands of pounds on like Dutch tests. I mean, it is outlawed. But I wanted to go on vaginal health because this is another bugbear of mine, and I know you love talking about vaginas, which is like great for me.
much
Um,
shock of my children.
well, I talk about it on national telly here. So on national TV, I often talk about vaginal dryness, and the shocking thing is people don't realize that genitourinary syndrome of the menopause exists, and I don't know what that's like in the UK, in the US. Sorry.
Same. There was this beautiful research that just came out that showed the most effective treatment for recurrent urinary tract infections in the US. We say UTI in menopause is vaginal estrogen,
Yeah.
and women are what? Now this is newer research, but I mean, as gynecologists, we've known this for years, recurrent UTI, vaginal estrogen. We know that the general urinary health is dependent on estrogen, and that deteriorates dramatically starting in perimenopause. And so again, every woman is different. Her symptomatology will be different, but it is so common. And then it leads to vaginal pain. I try to describe what the vagina looks like under a microscope, pre and postmenopausal. Premenopausal, multiple layers, very thick, juicy, lots of mucus, just gorgeous tissue. Postmenopause, it looks like a desert. It's an thickness. The blood supply is diminished. There's no elasticity. The collagen is decreased. And so and all of that leads to increasing prolapse, increasing urinary tract symptoms, increasing pain, decreased mucus production. And so I do a lot of talk around lubrication, lube, every sexual encounter, every time. And, vaginal estrogen being so safe for almost everyone,
And that's the thing I want to pick on, because people really worry about estrogen being unsafe, but vaginal estrogen is totally different.
No study has ever shown that vaginal estrogen causes cancer
Yes,
anywhere.
I'm so glad you said that.
And so what I try to do an analogy with my patients, and I say, look, it's like I'm giving you a topical cortisone cream, which you could go get at Walgreens for your rash right here on your arm. You're going to rub that on, okay, versus prednisone. And if you've ever been on prednisone, you know what it does to your body. It's needed in acute inflammatory situations, but and so that's the dose difference. It's a micro dose that is meant to act locally. Very little is absorbed in the bloodstream. It's an ester, and the chemical formulation, very little is absorbed. It almost, even with breast cancer, it's recommended.
It's recommended with breast cancer, if you had womb cancer in the past, because it doesn't get absorbed into the bloodstream, it doesn't go high enough. So you don't need progesterone cover at all, so you can safely have it. And I started it on even women who are breastfeeding, because sometimes the fluctuations in estrogen can cause a real dryness and an itch, and it's safe to give even whilst women are breastfeeding for that moment. And I think that we don't, there's such a shame and taboo talking about around vaginal symptoms. And thank goodness for social media, because now women because recurrent urinary tract infections, or UTIs, are the bane. They cause more hospitalizations, more. Yeah,
No
I
problem.
would love to do that. I wanted to go on to the next bit, because lots of the questions about nutrition and diets, which obviously is
Mhm.
your baby and your specialism. So another question is I'm coming up to the midlife, and I want to know how I can be in what nutrition should I be aiming for better health?
So the only thing I was taught in medical school and residency was calories in, calories out. And good nutrition was kind of like in the US, the way we define pornography. You know it when you see it. And we really had no formal nutritional training. And I don't know if it was the same for you in medical school. And when it came
No,
to
we
someone
don't have any.
overweight, we didn't know anything about the difference between subcutaneous and visceral fat. Like that I learned in my nutrition courses, which I did it 4 years ago. And we learned, the only way to manage your weight was calories in, calories out. And so when I went back to learn more about nutrition, I just got my mind blown from all, again, misinformation, things that just get indoctrinated in medical training and passed on, and things that I had even said it to my own patients, like, you must not be working hard enough. You must be eating more calories than you think you are. You really aren't working out as much as you think you are. It just blows my mind that I allowed that to happen, but now I'm trying to undo all the wrongs. So, things that, if I could just give your followers like my top 3 tips, one, most women in the US, and I assume in the UK, what they call the modern Western diet, which both of our countries, it's similar, are not getting near enough fiber in their diets. They are getting less than 50% of the recommended daily amount of fiber, unless you're a vegan or a vegetarian, and that kind of has other issues, with B vitamins and stuff. So my top tip for any woman who comes to me struggling is, what are you eating? I eat healthy. Okay. What are you eating? Well, I eat healthy. Okay. Let's get a nutrition tracker. And there's several for free. My favorite is called Cronometer, Cronometer. If one of your followers wants to type that in the comments, it's a free nutrition tracker. My daughter, who's a nutrition science major, pre-med, is trying to told me about this website. It's what they use in school. It was built not for
Wow.
calorie or ketosis. It was built for nutrition tracking. And so it really gives you a beautiful outlay of how much calcium, how much potassium, how much magnesium. So I try to change the mindset around just counting calories to counting nutrition. And there's a few core things to count: fiber,
Mm,
vitamin D. You know, are you getting enough vitamin D?
yeah.
Magnesium is crucial at our age. Calcium, you know,
Mm,
bones, everything else. Like, let's just track these things and then see where you end up. The fiber alone will do several things. If you're not getting enough fiber and all of a sudden you start increasing the amount of fiber in your diet through legumes, whole grains, avocado, seeds, nuts, you know, all the healthy ways to get fiber in your diet and possible supplementation. But
mm,
really, the majority of your nutrition should come from food. We only supplement a healthy diet. Your blood sugars will go down. Your fasting insulin levels will go down. So your hunger will go down. I mean, insulin is the fat storage hormone and the hunger hormone. And so I start
mm,
talking a lot about that. And our insulin resistance naturally increases with age, and it really goes up in perimenopause and menopause. Because of our declining estrogen levels in perimenopause, our steroid hormone binding globulin, which is the carrier of our sex hormones in the
mm.
bloodstream, decreases. So the activity level of other hormones increases because there's more unbound or free. Okay, now this gets a little technical,
Right.
but as our free levels of our androgens increase because estrogen's decreasing and the binding globulin's decreasing, those increased androgens are driving more insulin resistance and more fat to the abdomen through the deposition of visceral fat. Visceral fat is the fat inside of our bellies that wraps around our organs. It is why women notice in perimenopause and menopause that their abdominal girth is increasing where they never had it before. A woman's
Yeah.
body composition will change if she does
Yeah.
exactly the same thing as she did in her 30s, where fat that was deposited, you still will deposit fat on your, you know, hips and thighs, but suddenly you're becoming an apple where you weren't before. Now this is outside of polycystic ovarian syndrome, which is kind of menopause, certain aspects of menopause on steroid, you know, early.
Yeah.
But so my nutritional recommendations are around decreasing visceral fat, decreasing inflammation. We don't count calories. I get women to let go of calorie counting and to start focusing on nutrition and to use other ways to measure their health outside of what that scale says. Okay.
Yeah.
In my clinic, I have a body scanner that can give us a fairly accurate measure of visceral fat, muscle mass, abdominal mass. So I'll have someone come in with a very normal body mass index, you know, her weight height
Mm.
ratio. And however, she has very little muscle and a tremendous amount of visceral fat. In the US, it's what we call the skinny fat. And she's very unhealthy. Even though her weight's good, she thinks, you know, oh, I still weigh what I did in high school. I'm like, this is you not going to be, you know, your muscle mass is so low, you're not going to be able to get off the toilet without help. You're not going to be
Yeah.
able to lift up your grandchild. You know, we focus, where do you want to be in 20 years when we talk about nutrition? We're not talking, you know, that you'll thank me in 20 years when you are running circles around other women your age and you're happy and you're healthy and your quality of life is amazing and you won't care what the scale says as long as you feel good and you're not having disease and aches and pains and you know, things that are making your quality of life so poor.
So when you are advising women in regards to nutrition, it's so good that you said it's not calories, it's about nutrition and what you're taking in, and then you've got to look at the composites of that. So your magnesium, your calcium. We have a lot of emphasis on B12 as well, and I say to my patients, please look at the B12 intake as well, because women walk around with deficiencies, not realizing that they have it. When you're looking